All right, well, let's go ahead and get started then. I'd like to introduce one of our more famous fellows. This is Justin Dubin, born in New Jersey, did his residency at University of Miami, and then we were lucky to snag him up here at Northwestern for a fellowship. He did a spectacular job and then got a job down in Miami at Memorial Health, which is a newer health system, which is going to be starting a urology residency. Um, Justin Dubin is an expert in telemedicine, an expert in social media, and today he's going to talk with us about telemedicine, direct-to-consumer care, and andrology.
Thanks again, Dr. Bennett, for that very nice introduction. I want to thank everyone for coming on today. My name is Justin Dubin. I am a urologist, men's health specialist, and today I'm honored to be part of the Advancements and Breakthroughs in Andrology series. And today I'll be talking about telemedicine, direct-to-consumer care, and andrology. I have no disclosures, but I also do want to say a big thank you to Dr. Brannigan, Dr. Bennett, Dr. Halpern, and the rest of the Northwestern staff and team. You know, in 2022, I was a fellow there, and I think it's very easy to say that that was one of the best years of my life, both personally and professionally. I'm so very grateful for the mentorships and the friendships that I've created, and the lessons that I've learned that I'll carry with me for the rest of my life, both medically and professionally. So I want to thank you guys very, very much. It was an awesome time. So just a quick outline of what we're going to be discussing today. We're going to be talking about telemedicine. We're going to talk about its rise, why it became popular, advantages, disadvantages. We'll break down some specifics in andrology and telemedicine, as well as direct-to-consumer telemedicine. We'll come up with some conclusions and recommendations here. So, of course, the rise of telemedicine is important, and it's no surprise that there was a significant rise in telemedicine during COVID, where we were stuck in our offices or our houses, which were our offices, and we were unable to really communicate with patients on a personal, physical basis. And our study showed that there was an almost 3 times global increase in usage in telemedicine. And we're looking at urology specifically. Urology and neurosurgery were really the most readily adopting telemedicine, and urology has always been known for kind of pushing the barriers of and accepting future technologies, and no different with telemedicine. This study showing that urology program directors, compared to COVID prior, were only about 10% were using telemedicine, and afterwards about 80%. Telemedicine became such a prominent part of the urology care for our patients that in 2021, the AUA created a telemedicine white paper where they really did embrace and accept telemedicine as a critical component to a urology practice and to care of our patients. I think the bottom line to understand here is that telemedicine ain't going nowhere. It's here to stay. And for that reason, we really need to understand how we can best utilize it in our tool, as a tool in our toolkit. And really that involves understanding the benefits and the risks that come with it. And there are a lot of benefits to telemedicine that will actually go through today. And I think the most important question that you have to ask is, does it work? And it actually is very effective, right? It's effective for care. And studies have shown that there's similar and sometimes even better health outcomes compared to traditional care. And when you look at the healthcare system, it actually shows that there is a decreased risk of all-cause or conditional related patient hospitalization and length of hospital stay. And that's a great benefit for our patients who don't want to go to the hospital if they don't have to, or don't want to stay in the hospital as long as or if they don't want to. And it also prevents us from, having to put a healthcare burden on the system. And, a patient who has an acute issue or a post-operative issue, we're able to view them via telemedicine now and really make a better determination of whether they really need to go to the hospital or they need to go somewhere to seek that additional care. So it's a really big deal. And, beyond the effectiveness, do patients like it? And the answer is yes. There is a high patient satisfaction consistently shown in surveys that show that even compared to in-person visits, patients really like telemedicine. And one of the real benefits is, of course, is access to care. We know that about 10% of adults have either delayed or did not even receive access to needed medical services. And when we're talking about health equality, health equity, there is this rate triples for men and patients under the poverty line. And there was a really good paper, review paper on access to care and telemedicine, and it really broke down access to care in three components. There was entry into the healthcare system, there was adequate supply of services available, and timely provision of care. And telemedicine is really able to address all of these issues and provide better care. And one entry into a healthcare system, we're really overcoming transportation barriers. A lot of patients, especially those in lower socioeconomic status, have issues with transportation, whether it's using public transportation or in rural areas having to go further distances to get the care they need. And now with telemedicine, we're able to provide those people with the care they may not otherwise be able to get access to. Provider availability, I think this is really important for andrology, men's health, male infertility, because we are a super subspecialized group of urologists and physicians, and there may not be a men's health specialist in their community or even remotely close to their community. But now with telemedicine, you're able to communicate with people, or they're able to see that get a male infertility workup, or that testosterone or erectile dysfunction workup that they otherwise wouldn't be able to. And timely provision of care. Long wait times, that can often be overcome by expanding your network of providers that you're around as a patient, right? If there's only one doctor in 50 miles, everyone's going to that doctor. But, by expanding your network through telemedicine, you're really able to get more immediate or more timely care. Now, cost is important. And we know that travel costs some money. Accommodations, what if you're a stay-at-home parent and you need someone to watch the child, or you need someone to watch your dog, or you may need to miss some work time, and going to and from, you may need to spend time on gas or your meals. And it's a real problem. I remember being a resident in Miami, and we would work at Jackson, and I had patients who would have to take off their job. They would take a 2-hour bus ride or spend $60 on an Uber that they really didn't have to come to the office and to have me talk about their labs, something that I could have probably done, now, and I did do after COVID via telemedicine. And, there's some really interesting data about the amount of money patients save. And, for patients who are traveling longer distances to see their doctors in clinic, there's data showing that they save $888 on average per visit. That is a huge amount of money, especially for people in lower socioeconomic statuses, right? And even patients who are traveling shorter distances, there was a paper coming out of the VA showing that even at shorter distances, patients are saving $124 out of their own pocket per visit by engaging in telemedicine. Now, this is a big deal, especially for patients who may need to do more than 2 visits every 3 months or so. This is cost is important, and money truly does talk. And telemedicine is really providing our patients a better opportunity to get care in a more affordable and convenient manner. Now, of course, it's great for patients, but there are also benefits in our practices as well. I mean, there is a decreased utilization of resources. When less patients are coming in, we don't have to use all the resources that we otherwise would be using now that we have telemedicine. I know for a fact that there is a huge shortage in MAs and nurses, so we're really able to more efficiently use our providers' time and our clinics and our clinic staff's time by using telemedicine. There's no need to continue rooming and booking people and doing all these extra things if they're at home. And we are able to provide, to many degrees, more timely care. As I had said, there's many situations in which a patient maybe isn't feeling good, they're acutely ill, they can't make the trip to see you, especially in urology. Someone's urinated, they're complaining of blood in their urine, or they have concerns about their incision, and you're able to actually provide the care via telemedicine, whether it's looking at their via video, looking at their urine, looking at their incision, you're able to provide appropriate care instead of just telling them to go to the ER. And then in a world of burnout, we do have this really nice thing that telemedicine provides us as providers, which is flexibility. I have had been sick before where I didn't want to get my patients sick, and I was able to stay home and still do telemedicine and provide the care, I think, just as well as if I was doing it in person. And that provided me the ability to do that. Some people may have a family member or a child that's sick that needs to be at home from school, and you're still able to take care of your patients. And I think that flexibility is really valuable to the wellness of us, the providers. Now, I really want to highlight this slide because, privacy and overcoming stigma, I think, is one of the biggest values that telemedicine has, especially in the men's health andrology space. We know that there is this perceived stigma of seeking and receiving care, and it is a major barrier when it comes to men's health topics. So much so that we've done a study recently that's pending publication. It's been approved, but we've discussed the abstract where we asked men under the age of 40 who receive erectile dysfunction or have tried erectile dysfunction meds, how, when they chose their medication, where their source of getting the medication, how they chose and what they prioritized out of that choice. And above cost, above convenience was privacy. Young guys don't want people to know that they're taking medications for men's health things. They don't want them to know that they have erection issues. They don't want to know that they have sexual health issues. They don't want people to know that they have fertility issues. And really, the office is not a great place for them a lot of the times. I think a lot of men, what they do is they sit in the office and they see that as almost an announcement to everyone around them that they have a problem. But now, being at the safety of their homes, sitting at, in their house, in their apartment, or wherever they feel safe, they're able to have a safe conversation. They have an anonymous conversation and a private conversation, not necessarily anonymous, but a private conversation amongst you and the provider. And I think that really makes a big difference in men's health. And, it goes back to this idea that men don't really want help from others. I call this the IKEA problem, right? So, when I go to the store or a guy goes to IKEA, he buys a piece of furniture and he's not looking at the directions, right? He's going to try and build this thing himself. He's going to work on it. It's going to take 2 times as long. And especially with IKEA furniture, it's probably going to come out wonky. One leg's going to be crooked. You're going to be sitting and it's going to just be, uneven. And then eventually, after all these times and trials and tribulations, you're going to go back to the directions, you're going to figure out how to do it properly, and you're going to get it actually done. And I think that's what a lot of guys do with their health. They don't want to talk about it. They don't want to really address their problems or seek help. Instead, they try to fix it themselves. And we know that a majority of patients go online for health information. About 33% of Americans go to YouTube. About 20% go to TikTok for health advice prior to really ever going to their healthcare providers for health information. And that's a problem because we've shown that men's health information on Instagram and TikTok is inaccurate, mostly because it's not given by providers. So, telemedicine in this sense really provides men with the opportunity to discuss these issues. It breaks down that barrier, allows for privacy, and it kind of hopefully will allow them to, fix their furniture as long as they don't have to announce to the world that they need to fix their furniture, right? So I think that it's a really huge benefit in the men's health space. But of course, there are some significant disadvantages that go along with telemedicine. First off, technological barriers. It's great, though, that 94% of patients do have access to devices for telemedicine, but of course, there still remains this digital divide. The data shows that men with disabilities, non-Caucasian men, men with lower socioeconomic status and those who live in rural areas still, despite having the technology at their fingertips, are not very technology literate and can still struggle with these platforms. Another thing that I really think is important to highlight is there is data showing that there are issues with patients who English is not their first language, and I deal with that a lot down here in Miami. And sometimes that interpreter can be lost in the telemedicine platform. So oftentimes what I find myself doing is when any patient who does not have English as their first language, I'm making sure that they're coming to the office, because I think that that can be a real problem in providing good, accessible care. Now, if you speak the language, of course, it's not a problem, but I think it's something we definitely need to continue to address, and education and on technology is very, very important. Now we do have important things like data security concerns, and 2023 had a record high 725 large security breaches in healthcare. That's over 300,000 healthcare records were breached daily in 2023, and that's concerning. I feel like every day we wake up in the news, there's some other cyber attack or cyber strike on the healthcare system, that someone is being held for millions and millions of dollars. And now I would say that I don't think that this is necessarily a telemedicine problem. This is a healthcare and EMR problem, but it does seem that telemedicine does provide more entry points for data breaching than the normal healthcare interaction in the clinic. But I do think that in general, this is a major concern going forward for all of healthcare. When we're talking about andrology, I think the lack of the physical exam is a glaring weakness that telemedicine does have. A lot of men's health issues are associated with multiple comorbidities, and not having a patient come in, getting their labs, getting their vitals or doing a physical exam, it can be problematic. And it's something that we may be missing a diagnosis of obesity, high blood pressure, diabetes, something that we otherwise wouldn't be able to diagnose. And especially when we're talking about men's health and male infertility, the genital exam is actually quite important, right? We need to check for varicoceles. We need to check testicle size. We need to check for the presence of the vas deferens. And oftentimes, those can help dictate the next steps for care, especially in male infertility. So it is something that we have to acknowledge and realize and kind of accommodate. This slide, I find incredibly frustrating for everyone because, as we know, there was some confusing interstate licensing laws prior to the pandemic that were all relaxed during the pandemic, and a lot of these Medicare telehealth flexibilities have been extended through December 31st, 2024 of this year. So the big question is, what happens in 6-7 months from now? What happens in 2025? What is the law and telemedicine regulations going to look like? The answer is, I don't know. I don't think anyone really knows. I think we're going to have to find out, but it is a concern. No one really knows what's happening. And that goes along with us as men's health specialists who prescribe testosterone. There are online prescribing different requirements vary from state to state. So, will that change in 2025? It's kind of a fluid thing that is always changing, and there's continuous inconsistencies in reimbursement for telemedicine. So these things can be obviously very frustrating. Fortunately, if you're in a healthcare system or academic center, you can get a little bit more help. If you're in a private setting, I think it can get a little bit more confusing. But it's something that you kind of have to really be up to date on, and you have to be on your toes and be aware of all these regulations, and it's frustrating. So that's kind of a quick summary of telemedicine in general, and I do want to now highlight specifics in andrology and telemedicine. I'm kind of going to, for time's sake, break down infertility, and then I'm going to umbrella all the rest into kind of a men's health, because I think infertility is a little bit different in regards to some of the aspects of it compared to the other men's health diagnoses, but which encompasses erectile dysfunction, hypogonadism, ejaculatory dysfunction, vasectomy, as well as Peyronie's disease. So let's start with fertility. And I think fertility is very interesting because we know that in couples fertility, about 50% of the time there's a male factor involved, and about 30% of the time it is strictly a male factor. And yet, data out of Northwestern shows that only 29% of men concerned about their fertility are likely to discuss their concerns with their provider. And when you think about why, I think it kind of makes sense. When we talk about the workup for fertility, it involves four things, is what I like to tell my patients, right? It's a history, a physical exam, blood work, and a semen analysis, which is the gold standard for your fertility assessment. And we do know that, one of the problems is that semen analysis. You're asking patients prior to, a few years ago to come into a cold, sterile, uncomfortable place and provide a sample by doing something that's deeply personal or, embarrassing or, just not comfortable for them to do in that setting. And there's data supporting this, right? We know that men prefer to perform at-home semen analysis versus in a lab. And can you blame them? I think that's pretty common sense. I think anyone would prefer to do this at home. And so because of that, I think we're really missing capturing all the patients that we should be in male infertility. We really need to do a better job in capturing this population, who is clearly responsible for a lot of the couple fertility. And then there's a huge unfair stigma on the female partner that, this can really help contrast. And, fortunately now in the last few years, there have been the creation of at-home fertility assessments that are accurate and accessible, Fellow and Legacy to name a few, and they're excellent products. And you're able to provide a sample at home from the comfort of your house without having to worry about all these other issues, driving somewhere, providing a sample. And I think it's really going to open up the setting of allowing a lot more men to get evaluated for fertility. And we do know that telemedicine has been shown to be effective for established infertility patients. So I think patients do like it, especially in an area where there's not many male fertility doctors out there. Telemedicine allows those guys from other further distances to get the access that they want. But I think, while the majority of the evaluation can be completed via telemedicine, we do lack that crucial exam. Varicoceles, testicle size, presence of vas deferens. These can be important aspects of a fertility workup that can, in the long run, really dictate what surgical intervention or medical intervention or IVF versus IVF planning involves. So it's something that we do need to acknowledge as a potential weakness in the infertility care of our patients via telemedicine. Men's health in general, I think, truthfully, other than like assessing a Peyronie's curvature, which you can still use a picture of a patient to assess curvature, but to identify and palpate the plaque, most can be addressed via telemedicine. However, when you look at all the breakdown of all, the guidelines for all the men's health topics, the guidelines in general do require a physical exam for assessment of these issues at some point. And more recently, about 2-3 months ago, the SMSNA, the Sexual Medicine Society of North America, and the AUA created a telemedicine and men's health white paper. I think it's a really great breakdown of all men's health topics in telemedicine. And they also concluded that in their view, men pursuing healthcare for sexual health issues require a physical examination from a specialist in that area. I do recommend you give it a read, but in general, I think, erectile dysfunction, and we're going to discuss some of these things, testosterone replacement therapy, ejaculatory dysfunction issues can really readily be, done via telemedicine. Quite simply, andrology is a match for telemedicine, and that's me matching with telemedicine. Great time. So let's get into direct-to-consumer telemedicine. And I think that this is something that we really don't think enough about, or we maybe think a lot about and don't really think about in its relationship to our patients. So let's kind of get into it. So what directly is direct-to-consumer medicine? So it is the idea that you are direct marketing a medication to a patient, right? Hims, Romans, Hone, Maximus Tribe, all these companies, what they're doing is they are offering highly branded patient-initiated treatments by facilitating self-diagnosis, right? these companies say, you have erectile dysfunction, I will give you the medication. You have low testosterone, I will give you the medication. Now, a majority of how they make money, though, is, a majority of revenue is generated from really the sales of these medications, right? And that's different from telemedicine. Telemedicine, the way that, physicians typically do it, is it's the remote practice of medicine with patients' interaction by phone or video. It's not here's a medicine because that's what you want. It's, okay, you're coming in, let me figure out what's going on. Maybe we give you a medicine. I want to do assessment. Maybe there's some other things going on. And, that is kind of a different approach and a different mentality from what we're used to. But is it effective? I think it is. There has been a huge rise in popularity of direct to consumer, and we don't have as much data after COVID, but we do know that there was already before COVID a 15,000% increase on online visits to these ED direct to consumer platforms in just 2 years. And even in 2019, there was over 11 million visits in the fourth quarter alone for erectile dysfunction DTC sites. And ED is a very popular one for direct-to-consumer. We know that 20% of all visits were for ED in the direct-to-consumer market, right behind UTIs. And back to our study where we assessed men who were getting under the age of 40, who were getting erectile dysfunction meds, who had tried erectile dysfunction meds, 31% of them were obtaining them from a direct-to-consumer platform. So it is a very popular platform. But who is it popular with? Well, there was a study showing that it's really popular with younger men under the age of 40, those with mid-range incomes, and those who are concerned about low testosterone. So it sounds like almost, as I would say, every bro, right? There's a lot of young guys out there who are keen to technology, understand its values, who we live honestly in a dated place where, people aren't going shopping, they're going to get Uber Eats, they're getting, their supermarket is delivering their food. They want convenience. They don't want to engage. They just want a problem solved. And honestly, there's a lot of benefits to direct to consumer for that reason. It is a on-demand interaction, right? A lot of the erectile dysfunction companies, you send it, you get a text, you fill out a survey, and boom, before you know it, you have a script for your erectile dysfunction medication. It does provide access to these medications quite easily for those who are uninsured, right? And at a relatively cheap level, right? You don't have to pay $250 to see me before you get assessed for erectile dysfunction and I give you a medication. And of course, one of the highlights that we talked about before was privacy and anonymity, right? You really are not telling anyone, or no one has to know that, you're getting these treatments. And it's very, very convenient. You're not even making a trip to the office. You're not making a trip to the pharmacy. There's no time off needed. You are getting direct to your house those medications shipped. And I think this is honestly one of the biggest benefits to everyone is, by advertising, these companies are really destigmatizing men's health issues, and they're destigmatizing the conversation. We've seen it before. I think Endo and Xiaflex had done such a wonderful job, bringing education to the Peyronie's disease, amongst men. And we're seeing it now with Hims and Roman and Blue Chew and all these other testosterone companies. More and more men on podcasts, on social media, are talking about their erections and what's normal, what's not. And I think normalizing those conversations at the end of the day is really going to drive patients towards getting help. It's driving patients thinking about their health, or who maybe were too embarrassed to get the help they were before. And I think that this is a really good opportunity that these companies are giving to all of us, really, to think about our health, our patients think about their health, and hopefully at the end of the day, get them in our doors as well as, get the help that they need. Of course, there are risks, right? There is limited to no contact with prescribers on many of these platforms. Like I said before, sometimes you get a text, and you fill out the survey and you're a good candidate and you get the medication. And there was a great study that, compared that assessment to, coming into the office, and it showed that you are overlooking potential significant comorbidities by lacking a full health assessment. And really what you're thinking about here is, DTC for something like erectile dysfunction, they're kind of providing the Band-Aid without figuring out what's causing the cut, right? And when you have someone come into your office, you're able to get their vitals, you're able to assess them, you're able to look at them. And in that study, it showed, you're missing obesity, you're missing diagnosis of diabetes, you're missing a diagnosis of high blood pressure. And it reminds me of the patient that we've all seen where, a 45-year-old guy who's morbidly obese comes in for erectile dysfunction. And I say, what medical problems do you have? And he says, oh, I have none, doctor. I'm completely healthy. And I say, when was the last time you were in a doctor's office? And he says, 35 years ago. And I say, sir, let's see what's going on. And you end up diagnosing them with diabetes, high blood pressure. I mean, the truth is, oftentimes in the men's health space, you're the first doctor that these guys see ever, or in many, many years. So we are missing an opportunity there by in many cases with the direct-to-consumer care. And that leads to provider knowledge and background. The data shows that of the ones that are engaged in direct-to-consumer, the providers are often internal medicine, primary care, nurse practitioners, or PAs. And that's not a problem. I have no problem with that. But it is interesting that we are a minority, the urologists and the men's health specialists, in the space of direct-to-consumer that are providing care. And, we are the subspecialists. We are the specialists who know the data, we know the literature, we know the guidelines, and that can create some concerns, which I will get to. And of course, when we're talking about direct-to-consumer and your goal is income and you're making money by prescribing meds, there is a concern for conflict of interest, right? Are these medications being overprescribed just to make money? And I'm not saying that's the case, but like anything, I always find it funny where doctors are always attacked for, we have big pharma in our pockets, but DTCs never really get any criticism in that front. And obviously, I don't think really any of that is necessarily true, but these are things that are always of concern. And all of the big picture of a lot of these risks then lead to a bigger picture of concerns for guideline-based appropriate care, which I will get to shortly. I had alluded to cost before, and direct-to-consumer cost is also very important because we had shown that telemedicine can save the patient a lot of money. But what about direct-to-consumer? Well, actually, interesting enough, direct-to-consumer care has been actually shown to be a bit more expensive than tertiary center care. Direct-to-consumer TRT has been shown to be much more expensive, up to thousands of dollars and more expensive if you see in the top right corner there. And ED meds are much more expensive than traditional care. And I've seen so many times guys come in, they ask, I ask them how much they're spending for their erectile dysfunction medications from the direct-to-consumer company that they're working or they're going to. And then I provide them, a good RX script, which is fractions of the price that they are paying for their Viagra or Cialis. And when we're talking about patients who, are mid to lower socioeconomic status, these numbers can be staggering, especially if you're on something like TRT for the rest of your life. Now, back to that discordant care. I do want to highlight our study that we published in JAMA in 2022, where we looked at direct-to-consumer care in the testosterone replacement therapy space. What we did was we did a seeker shopper study. So basically, we had identified 7 different companies that were providing direct-to-consumer telemedicine care across all 50 states. And what we did was I pretended to be a secret shopper. At the time, I was a 34-year-old man who, according to our script, had signs and symptoms of low testosterone, low energy, low libido, erectile dysfunction. But what was very important was that I desired future fertility. And for those of you who are not familiar, one of the biggest side effects of testosterone replacement therapy is that it can cause infertility in patients. And often we do not recommend starting testosterone replacement therapy in men who are interested in future fertility. So I went as a secret shopper to these 7 companies, and I had a full blood panel, and I had my testosterone done. My testosterone level was 675. The AUA guidelines state that a level of 300 or lower is considered low. Our treatment goal is 450 to 600. So my testosterone, there is no question, was above normal and did not need to be treated. And with the desire for fertility, I should not have been a good candidate to be offered testosterone replacement. Now, despite that, I was offered testosterone replacement therapy by 6 of the 7 direct-to-consumer platforms. When I asked the companies that were offering me therapy what their treatment goal was, several of them, 50% in fact, said they had a goal of 1,000 or higher. And we do know at super therapeutic ranges there is higher risk for things like increased blood thickness, which theoretically could cause a heart attack or stroke. Now, this study kind of came about because of, we started seeing, and I still see a lot especially here in Miami, a lot of young men who come in who are trying for fertility, who ended up getting testosterone for a year or 2 years by some direct-to-consumer company. And they come in surprised that they have no sperm in their ejaculate because they were not educated or informed by their, direct-to-consumer provider that this was a risk. And we were seeing it enough that we decided to do this study. And it's continuing to be a problem, and it is a concern that some of these companies, and especially when we're talking about things like testosterone, which have a higher risk profile than erectile dysfunction medications, which truly are very, very safe, discordant care across the board, that we did see here, is a real concern for patient satisfaction, future patient goals of family, and overall risk to their health. So it's something that we do need to acknowledge. We need to continue to explore the space of direct-to-consumer care, and we need to make sure that people are getting the best care possible, the safest care possible. It's not always about just access to a medication. So after reviewing everything, what conclusions and recommendations can we make from all of this? Well, first off, I do want to show you the telemedicine and TRT. I don't want you to be discouraged by that last slide in our secret shopper study. Telemedicine and TRT can be done. It can be done safely. It can be done through AUA, concordant care. This was an algorithm Dr. Halper and Dr. Fantis and I had created during a publication with an algorithm that we think is a good one for providing guideline concordant care. Obviously, the important things are understanding what makes a patient eligible or ineligible for testosterone replacement therapy. And that goes back to, being the specialist. And as the specialists, we are the ones who have to make that determination. Conclusions on telemedicine. I think obviously it's clear to say that telemedicine is here to stay. I do think it is really an excellent platform for andrology. It's an excellent platform for men's health. It's an excellent platform for guys who either don't have the time to take off work or are too embarrassed to come into the office, or who just want access to a provider without having the inconvenience of going anywhere to get the care that they otherwise wouldn't be able to get. Of course, there are limitations, but I think that after showing you everything in this talk, you can see that it's easily incorporated into an andrology practice. Telemedicine is very, very possible. Conclusions on direct-to-consumer care. Once again, I think it is here to stay, and I think they are doing a really wonderful job of normalizing men's health conversations. And the way that I see them is I see direct-to-consumer for many patients as a gateway to future care through us. Direct-to-consumer puts out a wide net to so many men out there. And some men will take their erectile dysfunction meds or testosterone replacement therapies from those companies, and they're going to be happy and they're not going to have a problem. But I will tell you that, and I'm sure that a lot of my colleagues have experienced this, that, it gets their foot in the door, a lot of men thinking about their health and getting, initial treatment. But at the end of the day, we all want this personalized care. We all want a conversation with a provider. And oftentimes, that initial, conversation about their ED or their thoughts about their erections or the testosterone that the direct-to-consumer care provider is giving them will lend it itself to a bigger picture about their overall health, about their overall wellness. And it can often end up having them come see a real specialist like us, the men's health andrology specialists. And I have seen so many people who probably otherwise wouldn't have come into my office, but because they tried a medication or because they were reading about some advertisement that one other company had proposed, they wanted to reach out and learn more about their health and their problems. So I think that there is a huge amount of value there in the men's health space that direct to consumer is really providing its patients and actually us. But of course, we have to understand those limitations and the risks that come with direct to consumer care. And by knowing those things, we have to continue to be the best thing that we can be for our patients, which is their advocates, right? It's important that we provide our patients with education and education on their health, education on the medications that they're taking, and we have to provide them with a safety net, that they can come to if they have any other problems. I mean, there is, these ideas where almost a hybrid care where I see some patients who are happy with the direct consumer care of their testosterone, or they're happy with their ED and they're seeing me for other problems. And I'm happy to provide them with the answers to questions that they may have otherwise, or provide them with guidance. And I've told many patients that I don't like how they're handling their testosterone management, or I don't like how they're handling these other aspects of their health. And, that's part of that patient-doctor relationship. But at the end of the day, you really have to be there for them and help them through their journey, through their health. Final recommendations, I do recommend you review the SMSNA, AUA, Telemedicine, and Men's Health White Paper. I don't think you should fight the inevitable, right? Telemedicine, direct-to-consumer is here to stay. We really need to adapt with it and understand how we can use them. And I think that while telemedicine is great, I understand it. Not everyone wants to use it all the time, but there is a pathway that should work for you, and you should be using it to some degree. And finally, I just want to remind you, DTC is not the enemy. It's here. We shouldn't be battling it. We really need to understand it. We need to understand more the risks of it, the benefits of it, and why patients like it, because patients clearly are enjoying the experience of direct-to-consumer care. And if we can understand more about that experience, maybe we can make our experience a little bit better, and they'll maybe want to come back to us more readily. So that's about it. I want to thank everyone for listening today. I want to thank Northwestern. I want to thank Dr. Bennett, Dr. Brannigan for having me. It's been a really wonderful experience. Thanks.
Nice job, Justin. I don't have any questions, but nice job. Nice comprehensive overview of telemedicine and how andrology can benefit from this now not so new technology anymore.
Yeah, thank you.
Hey, Dr. Dubin, I do have a question. How are you doing? That was amazing. Thank you.
Thank you.
So what do you think things are going to look like in 10 years with the technology part of it? Will we have enhanced ways to, gather data on our patients? I find myself right now, especially with the exam, which you talked a lot during your talk about that being a limitation. Is there any workaround for that in a remote fashion? Are we going to have better imaging or other tools that we're not even thinking about now that might help us with assessing the patient physically? And then again, what will this look like in 10 years with the technology?
It's a great question. I think that one of the ways that we can overcome the physical exam, and we talked about this in our algorithm for telemedicine, is if it's not possible, first off, a lot of the times the exam doesn't matter. There's a lot of data for vasectomy showing that, even telemedicine, we're able to most of the time proceed with surgery. And there's a lot of data showing a preoperative assessment for a patient for a surgery does not impact the outcomes of the surgery or the final decision on the day of surgery to do it. But when we're talking about the men's health space and infertility specifically, I think it depends on the situation, but oftentimes you can ask if there's a primary care doctor closer to the facility that they can at least get a general exam, whether it's a DRE, a genital exam, and that may be a relationship with that primary care provider that you may have to create. But yeah, I think that there are, unfortunately, I know that, during fellowship with you, you had people from 4 or 5 hours away we were doing telemedicine on, and you really weren't able to do an exam because it wasn't practical. And oftentimes that you can proceed with a procedure, you can proceed with things before then. But I think having a good relationship with some primary cares in the community would be important in that, and I would recommend that they talk to their primary care to at least get an assessment annually. When it comes to newer technologies, I'm intrigued by the VR goggles and things like that, where you can maybe go into a room that you're not physically in, and then maybe there'll be a satellite facility where you can put on goggles and almost do at least a not touching exam, but really do a nice visual exam. And for things even like a grade 3 varicocele, you can pretty much see it, and you can have maybe some kind of MA or nurse on site who's able to do some kind of injection for trimix for Peyronie's disease assessment or something like that. So I think there are these ideas of satellite facilities that are almost a halfway point for a lot of places that have less access to care, to provide a adequate exam. Maybe not the best exam, but a better exam than we're able to just in standard telemedicine now.
Yeah, I mean, I could really see that. I mean, I think that's really what you're saying is actually really novel. But having a satellite standalone place for this kind of provision of specialty care to support, maybe not having a primary care doctor there, but someone who can facilitate. Well, maybe a primary care doctor can facilitate exams and the other sorts of things that maybe not subspecialty trained hands, but physician trained hands that can maybe help bridge the gap between the two. I mean, there's some parts of this country that are so far away from subspecialty care, as you were pointing out in your talk, that there could be a niche market for that in some parts. So anyway, but thank you so much for your talk. Really enjoyed it, and I mean, I look to you as being the leader in this area. So
Thank you very much,
really
Dr.
appreciate you taking the time. Thank you. Thanks, Justin.
Thank you.
Hey, Justin. Had
Hey, what's
a
up?
quick question. I really enjoyed your talk. In terms of the secret shopper study that you did and the platforms, I know I'm familiar with some of the platforms that have, advisors who are men's health specialists, such as HIMSS and Roman, that help kind of direct some of the, algorithm and treatment plans for ED and PD. But in your experience for the kind of the testosterone related platforms, are you aware of, are they at all any sort of urologist on the staff that can help guide that, or do you have any thoughts on how we as andrologists can ally with some of these DTC companies to harbor safe fertility practices for guys who want to be evaluated for testosterone? And what are your thoughts on that?
So there are several companies that actually are urology, created by urologists or driven by urologists in DTC. I'm not gonna say names of any companies, but there are several. I'm not saying that we did or did not have them in our study, but yeah, there are some, and I think it's important. And it's an interesting question, because the question then becomes, what do you want to do with your career, right? I think that there's room for both, but these kinds of things can take on a very big commitment, right? I mean, I know a lot of people who have left urology, who have gone on to help either Romans or HIMSS or these other companies, these DTC places. And I agree, there is, while there are some in the space, I think there's always room for more education, as you can see, or improvement of these companies, as you can see from the study. It's easier said than done, because it takes a special person, because a lot of people, we are doctors, we like to get into healthcare because we want to help people. People like the patient experience. People like to operate, and it is a different mindset, but I think that there is obviously always room for improvement in the space, and room for more minds to be involved.
Great talk, Justin. This is Chana. Hey, what do you think the role is of AI in this space going forward?
It's a great question, and the question, I think, really is going to be, to what degree are we going to even use providers in DTC anymore, right? At what level? I think the algorithm, and I'm sure people are working on it. I think the algorithm for screening and working up these patients is going to inherently change. And with AI, the question is, proving that they can do an adequate assessment without, and then saying, this is who needs to be seen, this is who doesn't. And I think that there's, it's a good thing because we're probably going to need less people to really assess people. But I mean, to some degree, AI is. I mean, they're so efficient with the direct to consumer ED meds where they're just having like text responses. So I don't know how much more AI needs to be involved there. But with the more complicated things like testosterone replacement therapy, you can create some really good algorithms through AI. It's just I don't know the legal ramifications of to what extent you can actually use it without getting in trouble or without using a healthcare provider to some degree, right? Is AI going to be, managing 5 patients and then one doctor is making sure that all the management of these patients are good? I don't really know, but I think that there is absolutely going to be an important role with AI in the next 2-3 years for sure, maybe less. All right, I think that's it. Well, I want to thank everyone. I really appreciate it. This was really great. Have a wonderful Thursday and have a great rest of your weekend.